We'll go ahead and get started, everybody. Thank you for your patience as we work through the tech issues, but I do want to welcome everybody to this presentation. It's Protecting Medicaid, Advocacy and Action. We're going to be providing an overview of the proposed changes and what those changes mean for Medicaid users in Indiana. And our presenters today are Tom Christian, Rachel Deaton, Macy Pohl, and me. I'm Mike Fodrell. And our organizations represented today are the ARC of Indiana, the Autism Society of Indiana, Down Syndrome Indiana, and the Indiana Statewide Independent Living Council. And we're grateful to be here with you guys today and for you to have to join us. A little bit about the accommodations for the day. We do have ASL, American Sign Language interpreters. They are panelists on this presentation, so you should be able to pin them if you need to. You can right-click them and pin them. And then we also have CART captioning, and that should be available if you click on the captioning button on the bottom of your screen. So if you need anything with that, put it in the Q&A, and I will address it as quickly as I can if there's issues with that. And with that, let's start with our welcome and I'll talk about our agenda. So what we're going to cover today. So we're going to do a welcome and introduction, so you'll get to know the panelists and who we are. Then we'll spend a little bit of time defining Medicaid. And then we'll talk about the federal and state Medicaid updates. And then we'll go through the Medicaid waiver reset in Indiana and what that is and what that means. And then we'll talk about why you need to be informed and engaged. And then at the end of our program, we will do some question and answers. And so during this presentation, if you have any questions, feel free to drop those in the Q&A and we will get to them at the end of the presentation. So thanks, everybody. We're going to talk a little bit about who we are, who our organizations are, and kind of what we bring to the table. So Tom, do you want to talk a little bit about the ARC?
Sure. Hi, everyone. Tom Christian, I'm the Chief Legal Officer for the ARC of Indiana. If you're unfamiliar, we're a statewide nonprofit that provides advocacy and other services for people with intellectual and developmental disabilities and their families. We have a mission to ensure all people with IDD are realizing their goals of living, learning, working, and thriving in their community. We have a variety of programs, including an advocacy network. So we're here to help and happy to be here today.
Thank you. And then next, I'm Mike Fodrell, the Executive Director of INSILC, the Indiana Statewide Independent Living Council. So a little bit about us, that our mission is to empower people with disabilities to live their own lives. And then we do that by working with the Centers for Independent Living on statewide issues that affect people with disabilities. And so we have a 3-year strategic plan that we're currently working on to improve the lives of people with disabilities in Indiana. You can find out more information about our progress on that and help us write the next plan in 2026 by visiting our website, and that is insilc.org. So glad to be here with you guys today.
Thank you. My name is Macy Pohl, and I'm the Executive Director for Down Syndrome Indiana. We are a parent-founded non-for-profit with a mission to enhance the lives of individuals with Down syndrome and their families through advocacy, education, programming, and support. We have a lot under our umbrella as the one-stop shop for all things Down syndrome. And we are excited to be here today and to get into more of the content.
Hi, this is Rachel Deaton with the Autism Society of Indiana, and I am actually getting inundated with emails with the links not working. So I'm waiting for Carly to give me the new link, as the link that she had sent was just for panelists. And so I'm working on that. I'm so sorry. I have 40 emails. So I'm waiting for Carly to get back to me. I'm so sorry.
You're okay. Let's take a pause for a couple minutes while we get this new link, because I don't want to dive into the content without a majority of those who registered, and if that's okay with all the panelists, so we can get that going and hopefully get people logged in before the content gets into, we get too far into the content. Rachel, I'm going to go camera off. I'm going to call Carly if that would be the best.
Yeah, because she said that's not working and she's looking. So that's the last email that I got from her.
Okay, thank you, Tom.
Hey, this is Lisa, the captioner. I just want to ask you to slow down a little and not be in such a rush when you guys are talking. It will help me a lot.
Thanks, Lisa. We will do that. I know I have a tendency to talk fast.
Thanks, I appreciate it.
I have the email all drafted. I'm just really waiting to copy and paste the new link in.
Thank you, Tom.
The direct link.
If you are just now coming into the waiting room, we're waiting a few minutes for attendees to enter for the new link.
Okay.
Rachel, Katie just sent you a working link. So she
I
did
know.
verify.
So that's a panelist link, and Carly said not. Is that okay to send the panelist link?
It's not a panelist link that I sent.
Okay, thank you. Then I got it.
We're up to 31 attendees.
Okay. I've just sent the updated link to everybody again.
Great. Thank you, Rachel.
Oh my God, it didn't work. It's not working in the email.
No.
It's downloading as a calendar event. It's not opening in Zoom.
The link isn't working now.
I'm not sure. It's opening up a calendar link, I think. Is that?
What we can do, I know that we have this already recording. I know we are in process of getting the link out. We can go ahead and get started in a few minutes. Tom, I know that you're kicking off things, and so we can start getting started in a few minutes and then send the recording out to those who are hopping on late, just so they can get that content as well. Does that work with the panelists?
That's fine with me. Yeah.
Yeah, that's fine.
Yeah, this is gonna work. This is what I sent her.
Okay.
Yeah, that works.
Okay, sounds like the new link is working for folks. So I'm hearing reports people are getting in. We're up to 38 now.
Okay, wonderful. Is this the new link that was just sent by Rachel to all of the attendees that were registered through the link?
Yes. Yep.
Okay. Okay, wonderful.
Yeah, and people are coming on. We're at 41, 42. So yeah.
Perfect. Excellent. For those of you who are coming in, we have paused our introductions into the content just to wait for more people to come in with the link issue. So we haven't dove into the content quite yet. We just did introductions and housekeeping.
And this is Mike. I just spotlighted our interpreter, had a request from one of the attendees to do that. And so did that as an accommodation for folks.
Are you guys ready for me to start then?
I think that would be fine.
Yeah, I think
Okay.
so. We're up to 45.
Gotcha. Thank you. Hello, my name is Rachel Deaton, and I work for the Autism Society of Indiana. I'm going to define Medicaid and give you a brief history of what Medicaid is. So Medicaid was originally created in 1965 as part of the Social Security Act to provide health care coverage for low-income individuals and families. In 1972, eligibility was expanded to elderly people and people with disabilities, and it was linked to the Federal Supplemental Social Security Income Program called SSI. And pre-waiver era, prior to home and community-based waiver services, comprehensive long-term care was only covered in institutional settings. And Medicaid implemented waivers in the early 1990s that allowed for parental income and resources to be disregarded. And this was determining medical eligibility. And then in 1991, the Family Social Services Act Administration was created, FSSA, on federal levels, umbrelling the OMPP and DDRS offices. And this was the foundation as Medicaid we know it today.
Okay, so I'm going to take over from here. Thanks, Rachel. What I'm going to cover over the next probably 40 minutes is going to be some federal changes and then some state level impacts and changes that are happening to the Medicaid program. As you're probably well aware, there's a lot of it. So we're going to try to run through the material. And again, if you have any questions, as Mike mentioned, feel free to put those in the Q&A, and we will have some time at the end to answer any. So first thing, let's just jump into federal and kind of what the landscape is from a federal standpoint. Macy, you could push the slide for me. So as we're all well aware, we had the record-breaking federal shutdown that we're just coming off of. So 43 days from October 1st through November 12th. It surpassed the previous record of 35 days. When the shutdown ended, Congress passed a funding package that did a number of things. First and foremost, restored funding to reopen most of the government operations, which was needed. Extended government funding for most services through January 30th of 2026. It brought back federal employees that were furloughed, paid back pay. And so it had a lot of, the shutdown had a lot of impacts. The funding source that opened it is good, but still has question marks because it certainly is a temporary funding patch. Relative to Medicaid, well, Medicaid benefits themselves were not interrupted during the shutdown. Agency functions were. So CMS staff capacity, processing of waiver requests, guidance releases, technical assistance. Obviously, if you don't have staff, you can't do what you do on a day-to-day basis, and that was true with CMS amongst other agencies. States are still experiencing the ripple effects of the slowdown and the shutdown. I think they will continue to do so. As I mentioned, the short-term CR that was passed to reopen the government is only a temporary funding patch until January 30th. So it's not a full year budget. So kind of the turmoil and the uncertainty that we went through before the shutdown up to October 1st, we're going to experience here in about a month again or 2 months again, as they're getting to the January 30 deadline to see if they can pass a full appropriations bill for fiscal year 2026. The next big thing on the radar, and again, we're going to dig into some of the details as we go into the slides here, but really some federal agency restructuring. And the administration has indicated they're going to do this. They've been saying they're going to do this, and they're kind of starting to implement some of these changes now, especially within the Health and Human Services Administration, and then even up to a couple weeks ago, the Department of Education. These reorganizations certainly affect oversight pathways, staffing roles, and how quickly states adapt and the federal government adapts to these changes as the funding flows through and other needed approvals happen. So again, not specific to Medicaid, but these structural changes can certainly impact the speed and clarity of CMS actions, both guidance and approvals and reviews. For states, it could mean longer timelines for waiver amendments, say, or state plan updates, all of which could certainly have an impact on people receiving services and people with disabilities. There is some temporary stability in the Medicaid operations. We mentioned the CR. Medicaid is considered a mandatory spending program. It's not discretionary. So it did continue throughout the shutdown. That meant that Medicaid payments generally expected to continue if things happen. But certainly, as staff are furloughed or limited, then the discretionary staff there could have impacts down the line. There's also some heightened long-term uncertainty I mentioned. We saw what happened in September about budget negotiations. That's going to trigger again here in January. So we'll see what is the sticking point on getting a 2026 budget. There's also certainly some national pressure to control Medicaid growth. And so that may have some interplay on the funding discussions and the budget discussions come January. And then finally, and we're going to dig into this right away, is HR 1, also known as the One Big Beautiful Bill, or OB3 or OBA. HR 1 is the bill that passed this summer, and it certainly did create some major structural Medicaid changes. I would say it's probably the most consequential Medicaid legislation in the past decade. It did a lot more than Medicaid, but certainly our focus today is going to be on Medicaid. And again, we're going to dig into these over the next couple slides, but it really restructured how states can finance Medicaid, which is really going to have a big impact on Indiana. It limited new provider taxes and a prohibition on increasing existing provider taxes. We're going to talk about provider taxes and dig into that. It also phased a reduction in the safe harbor limit for provider taxes down. Again, we're going to dig into that. But because HCBS makes up the home and community-based services within Medicaid, makes up more than half of the national long-term care spending, people with IDD are certainly going to see these changes and feel these changes more acutely as they get flowed down to the states. And states certainly are evaluating, including Indiana, how these federal shifts will impact eligibility rates, capacity over the next several years. So kind of going to the next slide, let's talk about OBA, OB3, HR 1. We're going to dig into the details of this because it was such a big Medicaid impact bill. I really want to kind of talk about what changes are happening. the risk of negotiations happening with Congress is that there are a lot of rumors and proposals that happen when negotiations are still happening, and they don't always come to fruition. So, what I'm going to focus on today is, okay, what is in OB3? What is in HR1? What are the actual impacts that happened, and what can we do about them? Or kind of pay attention to. The first thing I mentioned, major Medicaid restructuring in the federal budget reconciliation in HR1. The bill really had some sweeping Medicaid reforms, and it restructures mainly, kind of importantly for us, how states can finance Medicaid and how federal funding matches flow, and also how that relates to optional services and how those can be funded. So for disability specific and HCBS systems, I think the structural changes are particularly significant, given the cost that they have. I do want to relay, a lot of the things we're talking about are very important and impactful issues that we need to be paying attention to. But there's a long runway on some of these. So there's room for them to change potentially if Congress can get their act together and negotiate changes. If people really raise the alarm on how these are going to negatively impact disability communities. So there is still some time that these might change. But as of right now, that's what I'm going to talk about kind of as the bill passes, what's here. Most of the Medicaid provisions are intentionally delayed in HR1. So I think the federal government recognizes that states needed multiple years to really reconfigure their Medicaid budgets, reevaluate their provider tax structures, and really plan for HCBS funding. So the bulk of it is gradual. So some begin in fiscal year 2027, but the majority take effect between 2028 and 2032. So again, a long runway. And states must plan now, though, and I think that's why the federal government gave them this opportunity, this runway. Even if implementation is years away, the long runway signals that changes are meant to be permanent structural changes and not necessarily temporary changes. So they're really giving the states opportunity to do that. HR1 includes long-term reductions in federal Medicaid spending. So again, a lot of the restrictions are on how states fund and the ability to states to fund their piece. So let's dig into provider tax a little bit. And again, we're going to get into a little more detail in the next slide, but provider taxes, just for everybody's kind of information, it's a special tax that hospitals and other medical places pay so that states can get more funding from Medicaid. States use these taxes to bring in additional and extra federal money, and then the Medicaid pays those providers back for caring for the patient. So states raise money by taxing these hospitals. So then they pull more federal money down, and then they reimburse the taxes that are paid. Is kind of how provider taxes work. If you're thinking, man, that kind of sounds a little sleazy, I think that's what the federal government is probably thinking too, and this is why they're putting limits on how to do it, because it's a mechanism for states to pull more federal dollars down and how they pay their piece. And so there are new limits on financing tools like this, and that will that will inevitably result in a slower federal match growth over time. So the Congressional Budget Office estimates that provider tax changes in HR1 alone could reduce federal Medicaid spending by $191 billion over 10 years. Just the provider taxes. So just those changes, $191 billion over the next 10 years nationally, with which, overall cuts are likely exceeding, obviously just this one provision. So, again, states are planning for the long implementation runway, but states are going to need to look at and reforecast Medicaid budgets, kind of reevaluate potentially provider rates, modify eligibility and assessment tools, prepare for decreased flexibility in funding and financing mechanisms. So it really is an important change, and the states need to pay attention to and kind of pivot from what they're doing now. So provider tax restrictions here, the big thing is a freeze on any new provider taxes. So again, in Indiana, we use that mechanism. We use that provider tax to pay our share and to pull more federal dollars down. So under HR1, that toolbox is now locked. So states cannot add new taxes to new provider classes, which removes a significant lever that state legislators have and Medicaid agencies have and have historically have had for any budget pressures the states might be encountering. So they're freezing and kind of taking that tool out of the state's toolbox on paying that amount. Another, besides not freezing new provider taxes, it's also limiting states from increasing current existing taxes they have. And HR1 blocks states from increasing new taxes. In Indiana, this is particularly important because we currently have a 6% provider tax, which is now at the top of the allowable limit under the old rules. In the past, if Indiana faced cost pressures or a reduced federal match, we could potentially have considered an allowance to raise that or a waiver to raise that tax rate to stabilize Medicaid funding, and that option is simply gone now. So we can no longer adjust that tax as a budget balancing tool, which is important because, again, that's how we pay our piece. But again, not just do they freeze new ones, not only do they limit increases, they're actually phasing out and reducing down what's allowable by the state. So from 2028 to 2032 for expansion states, which Indiana is a Medicaid expansion state, HR1 is reducing the allowable provider tax down to 3.5%. So that safe harbor allowance, kind of the maximum level of provider tax that a tax revenue a state can generate, is at 6%. We are at 6%. From 28 to 2032, that's going to be on a steady decline to a maximum of 3.5%. So, think about those dollars that if we're getting from a 6% provider tax now, that's going to get reduced down to 3.5%. Think about simply the less amount of dollars that the states have to pay their piece. And Indiana specifically is going to they're going to lose billions in financing authority over time when we get forced down to 3.5%. And that's going to have to be filled, obviously, in other ways. So even though the reduction is phased in, we have to plan now. This is an immediate need because the change is going to fundamentally restructure how we pay our piece. Certainly for people with IDD, this matters because, as we all know, HCBS services are among the most expensive Medicaid supports, and we're heavily dependent on stable financing mechanisms. So that's going to be a big key. I want to note here that nursing facilities and intermediate care facilities for individuals with intellectual disabilities, so NF and ICFs, are carved out of the safe harbor reduction, which is interesting. It really just want to point that out as it creates a disparity. Institutional care remains better protected, and HCBS are not receiving the same protection. So I wanted to kind of highlight that. Moving on to long-term implications really for HCBS. I mean, I've kind of indicated some of this, but, if we have a reduced federal match, we're going to have less federal Medicaid funding over time, and there's going to have to be changes to Medicaid funding, and HCBS is a Medicaid funding. So Medicaid HCBS services are especially expensive. They're not federally mandated in the same way nursing facility care is. They're optional services under Medicaid. So how states might respond, they could slow the expansion of HCBS. They could add wait lists. Have we seen those start take effect? They could reduce the pace of new waiver enrollments. They could tighten level of care thresholds. These are all things that the states might look into doing as a result of this. Certainly, there's going to be increased pressure to contain or reduce waiver costs, and we're at a time right now that we're already exploding our Medicaid spend. So we're kind of compounding the issue here from a spend standpoint. So as states lose that financing flexibility, they're going to face pressure to control Medicaid expenditures even more, and we're going to have to kind of see how that takes effect. Certainly, the possible areas of concern that we're looking at are eligibility, services, and rates. Those are all bad things. So eligibility is one of the most effective cost control levers the states have, reducing who's eligible and how many people are eligible. We're going to get into this, but we're moving from the LOCC level of care tool the state uses to an inner RAI tool. The purpose is not, as stated by the state, to have less people be eligible, but they've acknowledged that that may happen because the new tools maybe do a better job of eligibility determination. Well, that may be a reduction in eligibility. In reality, states may reassess which services they offer and at what intensity. We're going to see that, already seeing that in some hourly caps, maybe monthly limits. And then certainly provider rates are a major part of cost structures, and states, may look at that as well. So those are the three areas of concern that we're certainly most concerned about. But really, I mean, IDD services are vulnerable due to the high utilization and the high cost. So, even though HR 1 does not specifically target IDD, its impact will certainly be felt in these issues, in eligibility services rates, and we're going to have to pay attention to that. Just to touch on some administrative and structural changes that came with HR 1, there are some new federal oversight and reporting requirements built in. There are multiple layers of federal oversight for states to comply with the new financing rules and cost containment measures. This increased oversight will certainly consume some of Medicaid's agency's bandwidth and FSA's bandwidth because they're going to have to respond to some of the oversight. It may delay some actions that the states are going to have to shift from what they're doing now to responding to some of the oversight inquiries of the feds. There are going to be stricter definitions for allowable financing mechanisms. We've talked about that already. And certainly and this is a good thing, on the flip side, while the oversight may take more manpower from a state agency standpoint, the increased transparency that oversight is going to have is going to be beneficial. States are going to be required to be far more granular on the information they provide, how Medicaid dollars are raised, how it's spent, how much is going from institutional versus HCBS, provider-specific rate methodologies. I think there's a lot of good information that can come from increased transparency, certainly. So that's something we can lean on and really educate and help us make more better informed decisions on Medicaid spend and HCBS spend at the state level. And then there's going to be some pressure on optional and non-traditional services. We talked about HCBS, as an optional service under Medicaid. States may look at those and how they tighten their budgets. Certainly, we have not heard any indication in Indiana that's going to be the case, but nationwide, it's going to be something to pay attention to. HR 1 does not directly cut services, but the administrative environment it creates places pressure on states to reconsider some of these things. And then I mentioned the administrative complexity is likely to increase. States are going to have to navigate more audits, more documentation, more reporting, more federal rules on financing. Certainly that's going to lead to probably slower processing and really kind of more conservative decision-making and delays, I think, in implementing new services. So that's kind of the crux of what we're looking at from an HR 1 standpoint. We can move on to some more just to kind of wrap up some federal context before we jump into some state stuff. Work requirements, we're going to touch on this in the state section too. There's been a renewed national conversation about imposing work or community engagement or volunteer requirements in Medicaid. These discussions pop up. They tend to resurface when in discussions about program integrity and workforce participation, and certainly when federal spending gets tightened. OB3 adds a new community engagement, quote unquote, work requirements for Medicaid enrollees. This will affect most low income adults from 19 to 64 will have to meet the 80-hour threshold of either work, schooling, volunteer, or quote unquote, other approved community engagement. Only a handful of states have really implemented work requirements before. Many states have tried. A few states have tried. They've always been challenged or paused. So it's going to be interesting to see how the courts implement some of these issues. I want to mention the exemptions. Certainly, there are exemptions built into the work requirements. Importantly, especially as it relates to kind of the population we're talking about today, individuals with disabilities or serious health problems are and should be exempted out. The phrase under OB3 is quote unquote medically frail. Parents and caregivers should also be exempted out, but a lot of that's going to be on state-specific exemption criteria. And so we're still waiting, and we'll get to it again on the state section, on what that state implementation is going to be on this. But the history of court decisions in this is something that we're at least going to pay attention to, and kind of how this is going to be implemented and allowed to be implemented. But there is a high risk to people with disabilities just from a misclassification standpoint. Even if we say there's an exemption, there's a high risk of being incorrectly identified and placed into a category where the work requirements will apply. And certainly we know even short gaps in eligibility can immediately disrupt very, very important HCBS services, therapies, medications, behavior supports. So it's really important. And certainly we talked about the caregiver coverage is particularly vulnerable, that even if they're expected to be exempt from the work requirements, details on who counts as a caregiver is not final yet. It's going to be depending on each state. But even so, the reporting requirements, documentation deadlines, like all the other overarching things that go to even show the exemption can be a lot and taxing. So a few kind of takeaways from the federal side before we jump into state. HR 1 is the largest driver of upcoming Medicaid changes. Provider tax restrictions reduce state flexibility, really how states determine how they're going to pay their piece. HCBS systems, particularly IDD services, are going to face significant pressure. There's going to be more scrutiny on hours and eligibility and rates. States need to plan now and prepare now for all those future preparation implementation dates. Even if there's a long runway, it's so integral in how they're going to determine how to fund their pieces. They got to work now, and they are. At least Indiana is. And then stability and continuity for people with disabilities is going to be absolutely central. I mean, the bottom line is that people with disabilities depend on Medicaid for nearly every aspect of daily life, from healthcare, personal assistance, employment support, transportation, behavioral support, housing stability. I think, as the states adjust to the federal changes, it is absolutely critical that stability and continuity really remain a guiding principle. And that's why I think from an advocacy organization standpoint, it's so integral for us to be on the forefront and be involved in these conversations as they're shaping what's going to happen at the state to make sure that is still the forefront, and that people with disabilities are the continuity of care and the continuity of services under the Medicaid system. So on that cheery note, we're going to move to state landscape. That was a very quick and I know I flew through that material, so I apologize, but there's a lot of material to go over, and I want to jump into states because there's going to be a lot. The big question now is, okay, we know HR 1 is making all these changes. A lot of those are frankly unsatisfactory, unknown how it's going to really apply and be implemented at the state level. And so that's going to be where our big concern is okay, now how are states going to pivot based on these changes? So kind of we looked at the federal landscape. Let's look at the state landscape. Right now, there have been some current HCBS waiver amendments that are under review with CMS. We're all probably well aware of the public commenting period that happened and the changes that are taking into effect. They're going to take effect December 31st, oddly enough, instead of January 1st, once CMS approves. But the amendments include major service changes. So restructuring behavioral support services, adding benefits counseling, limiting rec therapy and music therapy, clarifying structured family caregiving and extraordinary care. And we're going to spend the next couple slides digging into some of these. Additionally, on the state landscape, the ABA work group has completed its recommendations. So that we're going to dig into those, but those are now moved to FSA for policy decisions. We expect some of those recommendations to require kind of regulatory or rulemaking changes, some probably waiver amendments, and also some possibly legislative language, particularly probably around school access and provider choice. Ongoing redeterminations, these are happening. Redeterminations remain really, frankly, one of the most disruptive parts of Indiana Medicaid right now. Procedural terminations are continuing to cause a loss of services amongst individuals who are and remain eligible, including individuals with disabilities. Again, I mentioned, but even short eligibility lapses disrupt HCBS authorizations, medications, and other absolutely needed services. So we're hearing reporting of ongoing challenges with reinstatement delays, documentation issues, communication gaps. We all know USPS is awful right now. So even getting mailings to them to know that they have something to mail back has been difficult. The next big thing is waiver reset, which Macy's going to touch on in the next section. That's going to be another big thing on the radar on the landscape. Workforce shortages and rate pressures are, not a thing of the past. They're still very much present. And then overarching all of this is the state administration's stated goal of limiting Medicaid spending growth to 2% annually. Secretary Robe has publicly stated that goal of spending limits at 2% annually. Over the last several years, it has been far greater than 2%. So it's not even a status quo aspect. Again, what are going to be the things we look at? Probably eligibility, probably services, and or probably provider rates. So these, align closely with the federal pressure created by HR 1. But together, I think these forces create a very significantly constrained fiscal environment for all services, but especially HCBS services, which again are probably one of the most cost-intensive components. What is one of the cost-intensive components of Medicaid? So it's something that we have to be aware of, and we know that is an overarching goal of the state right now. So jumping into some of those, kind of digging deeper into some of those issues, the HCBS waiver amendments, again, we're looking at a December 31st implementation date for these. I'm sure everyone on the call is well aware of a lot of these because there was a lot of press and advocacy that was happening during the public comment period. But recreational therapy and music therapy are going to be limited to 6 hours per month. The state's reasoning on that is that the hourly caps increase equity amongst to spreading provider capacity. The services, specifically rec and music therapy, are intended to be supplemental and not primary supports. And cost containment is necessary to stabilize the overall waiver. And certainly families and providers will both need to adjust care plans to stay within these limits. The behavioral support services, the state's proposing a redesign to the behavioral support services to split the service into subcomponents for clearer definitions and specific hour limits. The redesign is going to replace that kind of less used intensive behavioral intervention service and really create a more stabilized approach. A good thing, part of this waiver is going to add benefits counseling, which will be great. Really help as a service, help individuals understand how Medicaid, how work, especially now with potentially work requirements, affects Medicaid, how earnings interact with things like SNAP and SSI and housing, really avoid losing essential services by increasing employment, which I know a lot of individuals are trying to balance. This is a positive addition, especially as we move into that employment first expectations, which is really kind of the key and the goal of individuals receiving services. And then structured family caregiving is another really big change here. We all know 2 summers ago, I think it was probably 2024 summer, the changes as it relates to attendant care and LRIs, legal responsible individuals. The structured family caregiving definition was updated, as well as the extraordinary care definition. They're clarifying and modernizing structured family care service definition to ensure more consistent delivery across the waivers. It also incorporates extraordinary care, which was the definition as part of House Enrolled Act 1689 last session, that really put some requirements on the state to receive advocacy and recipient input on what that definition needed to look like. And so they did go through those and got some good input on what extraordinary care needed to look like. And this is really for caregivers who perform significant high need support tasks under structured family care. So this is an important adjustment for families to provide that full-term care as they step into kind of a highly skilled role in that service provider standpoint. So those are the big ones out of the HCBS waiver amendments. I'm not going to spend any more time on those. I think there's a lot of discussion that's been happening in the advocacy world on those already. So the ABA work group, if we can remember back, and Macy, this is the next slide. There was a lot of changes in the ABA world last January. It does not seem like almost a year ago, but it was almost a year ago, where the state agency put some lifetime caps that were retroactive on ABA. This was one of the highlighted areas they saw of drastically increased spending, and they said they needed to put guardrails on. And so they immediately put guardrails on. This immediately raised alarms because people who were receiving ABA therapy sometimes maybe were retroactively limited out of any future one. So there's a lot of advocacy that happened last January that resulted in an executive order by Governor Braun to assemble a work group for ABA. This included representatives from providers, insurers, state agencies, advocates, families, to really talk about the system as a whole, evaluate the system, identify pain points, and propose improvements for both coverage and delivery of services, with the overarching cost goal, I think, if not the back of the mind, at the forefront of the mind. And so the ABA work group has concluded its work. It's released its recommendations, and some important themes I wanted to touch on. They want to tighten and clarify credentialing and ensuring that provider agencies have a state-determined accreditation. I think this is important because we were seeing over the last several years a lot of ABA providers just kind of popping up and putting a shingle out, and there really wasn't a requirement on quality of services or really something to hold them to from an accountability standpoint, a quality standpoint. And so I think the credentialing is a good thing, ensuring that the providers out there will be properly accredited. It also sets standardized BCBA to RBT supervision roles. I think this is going to increase quality and consistency across ABA providers statewide. There's a concern that was raised through their work group work on lack of coordination between school-based services and medically necessary ABA services. So I think that came out of it, and I think we're going to see some legislation that may be brought on that this coming session. So standardized clinical models and rates. For one, I think coupled with a lot of ABA providers popping up, the recommendation is to implement a temporary moratorium on new ABA clinic sites. And I think that is important to ensure the quality of new providers. So that was included. Minimizing additional barriers for RBTs to participate in Medicaid networks. I think that's an important aspect, as well as establishing fair and predictable reimbursement rates, including a potential quality incentive payment, which are all important. I think these recommendations are aiming to promote predictability for families, but ensuring quality across the system, which over the last several years we thought was important. There's also some parent training expectations, which is good. I think this reflects kind of the broader national push toward family-centered behavioral health models. There's a requirement for 12 to 18 hours of caregiving coaching per authorization period, which I think is helpful. So next steps from here, we're going to look, I mentioned, at the kind of landscape slide, what are we going to be looking at? Really move into decision-making phase now. The work groups made their recommendations, which recommendations can be done regulatory through rulemaking, which are going to potentially need a waiver amendment, which are not going to need legislative action. I mentioned the school-based access is potentially going to be legislatively. So we'll see how those unfold, and certainly we're going to pay attention to those and advocate as needed. Moving through the waiver system, I think we all are well aware and recognize what's happening in the waiver system now. I've spent the last half hour talking about things that are affecting the waiver system. Certainly, it's going to be impacted by all the changes I've talked about. The number one thing I think is, growing wait lists. We've seen a renewed growth in wait lists. We didn't have a wait list for many years. That was a significant and important step that we had accomplished over the last decade, and we're back now. And there's thousands and thousands of people waiting now on wait lists, and something we've not experienced at this scale in years. I mean, certainly a wait list means delayed access. That's what it means. An individual who needs services cannot get services because of the wait list. So, that's important, and that's an urgent thing that we recognize. Recently announced the FSW and the CIH waiver are now maxed out on their caps. So we're going to see more wait lists. And that's, the CIH waiver, when it's supposed to be an emergency waiver, where do emergencies go now? And I think that's a concern and a problem that we're going to have to figure out from a state system. DSP shortages, again, this is not an issue of the past. We're continuing to see DSP shortages, and it's really a significant bottleneck in the system. I think providers are seeing vacancies, there's high turnover, there's severe competition amongst other sector wages, service sector and retail sector wages. So there's also difficulty supporting. It's a hard job, right? I mean, it's a high need individuals have complex work environments. So those are going to be difficult. And so even when funding and authorizations are available, services cannot always be delivered without the necessary DSP. So that's going to be obviously an overarching thing that hasn't gone away yet and hasn't been solved. Rate adequacy concerns goes to this. This is compounded certainly by some HR1 changes. And then there's going to be, we continue to see potentially gaps, and we're hearing families report inconsistent access across multiple service lines, whether it be therapies or respite or residential supports or employment services. These gaps are caused by a combination. We talked about workforce shortages, rate constraints, provider capacity, regional disparities, urban versus rural, administratively complexity. There's a variety of reasons for this, but we're continuing to see gaps in services. And then, as we're beginning a new legislative session, certainly there's legislative scrutiny on Medicaid spending. I think Indiana legislators are certainly paying close attention to Medicaid spending at a time at this time, and they're going to continue, as Secretary Roba is talking about the 2% flat. Key drivers. There's been a sharp increase in Medicaid expenditures during and after the pandemic. That's just a given. It's a reality that we're dealing with. There's concern over redetermination trends. HR1 is reducing federal support. They're shifting more responsibility to states, but they're limiting how states can fund their piece. All these are real issues that the legislator is paying attention to. And this scrutiny means that, waiver programs are under a microscope, and we need to recognize that. And so legislators are asking, kind of where the money's going, what services are producing measurable outcomes. For the disability community, I think this increases the urgency for clear data and transparency and strong advocacy, consistent storytelling about the need for these services, all really, really important things. So moving to the next slide, level of care, I mentioned this earlier. Indiana is changing the tool that they are using to determine the level of care. So they've previously used LOXI. They're moving to an inner RAI assessment tool. They're transitioning away into this inner RAI. I think this is part of a broader national trend toward using validated research-based tools to be more consistent across states and service systems. Again, the stated goal of the state is to improve reliability and consistency, is to enhance clinical accuracy and better alignment in assessment results for waiver eligibility and service needs. However, I think the state has recognized that, and they've stated that the inner RAI tools, I'm never going to get an easy way to say that, they should be named as something else, are going to do a better job of assessing, right? They're going to do a more consistent job of assessing. And inevitably, some individuals who have been previously found to be eligible under LOXI might not be found to be eligible under inner RAI. So while the eligibility criteria is not changing, if the tool that they're using for level of care assessment is tightening or doing a better job, then there's probably going to be significant implications on eligibility and scoring and access. And we're paying attention to how those are being implemented. And so I think it's going to be important to see that. I mean, certainly any transition in eligibility tool is going to have risks. So that's just a given. We know that. There's going to be some hiccups at the state level, really kind of moving into the implementation. But the scoring consistency, I think, is going to be something that we need to kind of recognize. And then, from a legal standpoint, the appeals, the due process given to an individual to maybe appeal those decisions, I think is going to be important as well. So that's, it's on the radar, it's happening, and it's going to be impactful, like everything else that we've talked about so far. One of the other changes I wanted to just touch on briefly is self-direction changes. It's one of the waiver amendment changes. Really, individuals serving as an employer, they're hiring, supervising, training. This is meaningful as a move toward person-centered control, but it certainly requires strong support from case managers and other staff to ensure. I mean, individuals, when you're taking on that administrative responsibility for families and individuals receiving services of scheduling staff and managing timesheets and making sure there's compliance with training, et cetera, certainly that's going to be a heavier lift. The state is allowed for self-direction in 3 specific services: rehab, residential hab, respite, and workplace assistance. The pay rates are going to be capped at a state established maximum, and there's limitations on guardians being paid providers. So that's an important caveat there. We talked about moving right along. We talked about the federal context for work requirements. Let's see how this is going to again flow down to the state. Unsatisfactory, we're not sure yet, and we're still going to have to see how it's being implemented. But certainly at the state level, policymakers are linking in on this, linking Medicaid eligibility to some form of training and work or volunteering or community engagement, also driven by HR 1's requirements. So, we're going to have to see how that's being implemented. I talked about some of those risks earlier about exemptions out for people with disabilities and caregivers. But it's going to have to be kind of determined at the state level how that's being implemented, and we simply just don't know yet. There's a risk of misclassification we talked about. Obviously, administrative burden. There's going to be, even if you're exempt from these requirements, there's going to be a requirement to show that you're exempt somehow, what I would imagine. And certainly there's going to be an impact on caregivers who, especially those individuals who are providing, say, 24/7 supervision or have individuals with complex medical needs, find time to also do this paperwork to show eligibility or exemption from this requirement. Implementation TBD, that we've not seen formal proposal yet, and certainly something we need to and are paying attention to. We're monitoring closely because even a small implementation choices can have really large consequences on both people with disabilities and caregivers. So wrapping up, as I've moved through a lot of material very quickly, some state, takeaways here. Whether we want to acknowledge it or not, our Medicaid system is in major transition. Not only the flow down from HR 1, but we're undergoing simultaneous high impact transitions here. HCBS waiver amendments. Macy's going to talk about the waiver reset. We have new assessment tools. There's obviously rate pressures, workforce shortages. We have redeterminations happening. The system is being rebuilt while we're operating at full speed, is inevitably going to create volatility, especially in a very high cost situation where there are a lot of fiscal pressures all shaping decisions at the same time. So again, paying attention to that limited annual Medicaid spending growth of 2% flat from Secretary Robe, certainly going to drive tighter scrutiny in all the programs, a reluctance to certainly expand services, pressure on waiver, reset, and redesign decisions. Everything is being viewed through a budget containment lens rather than a service expansion lens. And I think that's key. And so why we need to, and again, Mike's going to touch on the importance of advocacy here. This is why it's so important. Not to steal Mike's thunder here, but obviously, you see all these changes, decisions are being made. And so we need to be active. I mentioned the waiver changes, HCBS pressures, new assessment tools are intersecting, waiting lists. We're going to continue to see those aren't going away anywhere. And so how those are being managed, how people are getting on waiting lists are going to be important to watch. And, I think to leave on this note, people with disabilities, people with intellectual and developmental disabilities, those protections need to remain central. these individuals are experiencing high service needs, high utilization of HCBS, and really sometimes a lifelong reliance on Medicaid and HCBS. Because of this, services are more exposed during times of fiscal tightening, which is we're in. But we need to ensure protection and continuity of services for individuals who depend on these services most. And that's ensuring access, stability, and continuity are really non-negotiable. And we need to maintain that from an advocacy standpoint, which I know is not going to be an easy lift, but really is going to be on the forefront. So, again, I know that was a lot of material in 40 minutes, but just for everyone, including my co-presenters, I stayed within my limits. So 20 minutes fed, 20 minutes stayed. If you have any questions, again, please add them to the Q&As. I don't know if we're whatever time we have on question and answer, we'll be happy to answer any questions. But I hope that helped, Macy, as I lead you into your waiver reset discussion.
Yes, thank you, Tom. And please, as we have these ideas and these thoughts top of mind, put it in the Q&A and we'll get to them at the end. As we speak on upcoming changes in systems and services, we also want to touch on upcoming waiver changes, which is a process called waiver reset. So in this portion of my discussion specifically, I'll talk about what the waiver reset is, what to keep in mind in terms of timeline and expectations. I know there's a lot on social media and a lot of information about this, so we wanted to kind of clear things up a little bit. And then also how you can be a part of shaping this process through feedback, through your lived experience. So I'm just going to give a little bit of a background first. This process actually started in 2018, back even before COVID-19. So DDRS and BEADS and partners such as HSRI, they actually have been working on this for a really long time. At the time, what was originally called a waiver redesign, and where they were only looking at 2 waivers being redesigned, now has developed into waiver reset, which is specifically looking and following the home and community-based service waivers, CIH, family support waiver, so FS, health and wellness waiver, so the H&W waiver, and then also the traumatic brain injury, so TBI. So when I go through discussions about waiver reset, those specifically are the waivers that are being looked at to be reset. And so a little bit about the process, as I had mentioned. So during this process, partners in the state have been working together to build out, and I'm going to be quoting this, to make services better, support people with existing resources that they have, make it easier to navigate the waiver system, make the program sustainable long-term, and ensure people have choices that fit their needs. So that was actually a quote from the reset verbiage that has been put out for the community to read and to understand the process and why they're doing the process. So the individuals who have been working on the waiver reset include individuals with lived experience and knowledge on the waiver systems throughout the nation. So a lot of the people on the team working on this have also implemented new waiver reset systems nationwide in other states. And they also oversee current waiver systems now. So state partners who are currently seeing how our state current waivers are being run, and then also community feedback, which I'll get to at the end here. So it's important to note that this process isn't just taking the current waivers we have now, which are the 4 that I talked about, and just tweaking them a little bit and saying, okay, this is the new waivers. This is a complete reset. So we're working from the ground up. I'm not intimately involved in this waiver reset on the back end, but there could be 2 waivers. There could be to replace the 4. There could be 1. They are still in the process of figuring out what that is going to look like based on research, data, how things are currently run, and community feedback. So it's all being discussed and reviewed. So all of this is still definitely in the stage of being worked through and processed. With this process being such a lengthy one, obviously I talked about this started even before COVID-19. Its impact, obviously, with COVID-19 shifted needs. And so that's why they're looking at the 4 waivers now. And I'm going to talk a little bit about the timeline now of what it looks like today of when you can expect changes. So in the next slide, I will go through, it's a graphic that they gave talking a little bit about the timeline, but I'll first talk with you guys first. So these changes are not happening tomorrow. Right now, the teams are working through public comment, public feedback, and they're actually even running feedback sessions, which I'll talk about at the end. So you still have an opportunity to give feedback, to give recommendations, and to share all of that. And so this is still very much in the process. What I think is most important about the timeline information that I can give, which was reconfirmed this week actually with one of the team members that are in this process, that this is not set to occur until mid 2027. So the goal is not to flip a switch and everybody is suddenly on a new waiver. They're going to try to navigate this in a way that it's a rolling. So what their goal is allow, and this is current goal, the current goal is to allow a year of transition. So starting in mid 2027, they'll go through the transition period. And the current approach being thought out is that individuals will be switched during their annual meeting. So during their annual meeting, that will kind of trigger the new waiver and they will go through that system then. As I talked about the timeline, I want to make sure I included language such as the goal is in the current approach very intentionally, because we're very much in that community feedback tweaking stage where they might decide something different. If you feel like, if they're going to change during my annual, but I'd rather just say, hey, I'm going to raise my hand and I actually want it switched as soon as we're able. That's something they want to know. That could inform their decisions in the future on how they are doing this process. So that's why I try to say the goal is in the current approach, because that's what they're looking at. And they want to make it as smooth of a process as possible because they know it's, getting all of these people on current waivers to a new waiver or to new waivers. It's going to be a process. And so they're trying to be intentional about how that's going to look. And it's not going to be just a flip of a switch, that there will be time for that transition. So I included this as well. This was just something that they had provided to talk a little bit about the waiver process. This will also be sent out to everyone just to kind of review and see, but this is kind of the working timeline that they shared. So this portion, and actually we will send some supplemental material after the meeting too, because we have some new information out about feedback, which came out yesterday. But really what I want to emphasize is, if you want to give feedback, input, the time is now. We are currently in that process and we're currently in this stage of community feedback. So the whole team really wants to know what is working. They want actual actionable feedback. So what's the problem? What is not working right now with the waiver system that you're currently experiencing? Maybe it's a waiver service that's hard to access. Maybe it's how you're able to access information about your waiver budgetary wise. They want to know what is not working and why it's not working. If you have a recommendation on how to make the system better, give it. They would love to hear your thoughts through lived experience, through being a consumer of the waiver services. What do you think would be better? How can we rework that? Because they are reading through every single feedback. They're reading through to see how they can rework things to be more accessible. And they also want to know from you what is working well. What's an essential to you that you currently could not live without? So what is allowing you from your waiver services, allowing you to go to work? What is allowing your individual to thrive in the community? They want to know all of this so they can be better informed as they go through this process. And they really try to work through what's working, what's not, and recommendations going forward. Lastly, communicate also what the process is like for you. Is if you want more information, if you think that there needs to be more communication around this process, that can be a feedback as well. If you would have recommendations on how to disseminate this process to community members, give that as well. So they want all of the feedback and they're in that stage right now. So I did put on this slide an email and I will make sure that that is sent out as well. That email is being regularly checked by the company and organization that I actually spoke to this week, who we were just talking about how they were coming through things that were coming through. So they're being actively looked at. And so I really encourage you to email your feedback, and you can email a couple times. Maybe you said, oh, I forgot to mention this. Email them a few times. They want those recommendations, they want that feedback. So that is the best email to send that. But also there is a feedback session, which we will send the flyer out after this meeting. And it is actually this Friday, December 5th from 12 to 1:30 Eastern time, and it's going to be on Zoom. There is a Zoom registration link that we'll send out with the flyer that describes what that feedback session will look like. But that will be a live opportunity where you can give feedback, give recommendations, and talk about improvements. So those are two ways that you can really get in front of those who are making these decisions and working through what these new waivers will look like, and say, hey, this is what I think, is working. This is what's not. These are improvements that I recommend, but also here are the things that aren't working for me. The goal is that after all of this feedback comes out, and once all of this feedback has been disseminated, they're going to pull out major themes, major things that they've been noticing that are trends. And they're actually going to form a public-facing document for the community to show that this is what the community brought to us, that are concerns, that are improvements, that are essentials. And so they are planning to give public-facing comments to just allow the community to know, hey, we're listening. This is what we are pulling out as comments and as things that need to be improved or things that are really working well. And if there are things that don't represent maybe what people are saying, give that feedback too. So that is the current waiver reset process, how you can get involved, but also what the timeline looks like. Like I said, I will be sending out that material about the upcoming feedback session, but also I really encourage you to email to give further feedback, improvements, and recommendations. That is everything on waiver reset. So I'm going to move the slide and mute for the next part.
Oh, thanks, Macy. I appreciate that. This is Mike with INSILC. And so that was a great presentation on the waiver reset and then on the waiver changes from Tom. Really appreciate that from both of you. And want to talk a little bit about why we need to stay informed and engaged, and kind of ties into the reason that we're having this webinar today. So we've heard a lot about those changes that are coming up at the state and federal level. And then Macy just talked to us about the reset and how that's working, how we can get involved with that. And one of the themes that you can really take from both of their presentations, I think, is that changes are coming quickly. They're coming kind of fast and furiously, and it's sort of day to day or almost week to week when these things are happening. So it's really important to stay as best you can up to date on the current situation. And the best way to do that is really to follow all four of our organizations. I mean, you can do that through our social media, through our website. We all have different ways that we can do that. And we try to push out the most current information that we can and help our constituents in the community stay up to date and aware of where things are going right now. And we know too that with all of these changes that are happening right now, that life is challenging. It's a lot. I mean, these changes are stressful. We have ourselves, our families, the people that we care about, our communities depend on all of these services, and knowing that they're kind of up in the air, and that these changes are coming and that it fluctuates consistently, it creates a lot of stress for a lot of us. And it's really important to do that, to have that connection and to stay invested. And one of the best ways that you can do that too is by reaching out to your local representative and your legislator, letting them know about your story, telling them your personal situation, how this affects you and your family. That way they can stay, current too on how these things are affecting the lives of real people, and that it's not just numbers and a spreadsheet and those kind of things. Or these actually, touch people, Hoosiers who live in Indiana. It touches our lives and affects us on a day-to-day and a very personal level. And letting them hear about that and know about that, I think, is one of the best ways too that we can stay involved and really help to keep abreast and keep them abreast of the situation. And then two, one of the things that I've been thinking about as well is that really, all of these changes, and we want to push back, and it gets really frustrating, I know sometimes, that all of these are happening. And sometimes I think that the most kind of radical and disruptive thing that we can do in this kind of environment is actually to show love and support for other people. And so, I think about that a lot, that just as times the way they are, that us having that attitude and trying to be supportive and respectful of each other and of our community is one of the best ways, I think, that we can kind of push back on some of these changes on a more systemic level, and just letting people know, again, that we're not going to back down to those things and that we are going to continue to provide that support for each other. And then I would just have a note too to everybody. Again, I know these times are stressful, so take a minute to do some self-care, whatever that is for you, or your family or your loved ones. Take a few minutes to do that and care for yourself, and that's going to help you also to stay, I think, more engaged and rest up and have more energy to keep up with these changes and to get your story out there and to let your community know about them. And then lastly, I would say if you have the capacity to support the organizations that are working on these issues, please do so. I think in INSILC and the 3 organizations that we're partnered with today are all fantastic resources and all do really great work. And if you have the capacity, again, to support them, whether that's financially or sharing their message or getting involved or being on top of their programs or sharing stories to your colleagues or your peers or your family about how they've helped you, that's all going to help us and help us to, again, to stay invested and engaged and to help try to make a difference through all of these changes. And with that, I think we're going to keep going and we're going to do get into the Q&A part of our conversation. And so we have some questions in the Q&A. And then again, this is a time for you to ask your advocacy questions. So this would be an opportunity to ask specific questions about advocacy strategies, to share your experiences and to get guidance kind of tailored to your situation. We can also have kind of an interactive discussion where we'll discuss real world scenarios, address the challenges you've faced, and we can brainstorm solutions together as a community. And then we'll do some shared learning. So learn from other people's experiences and strategies. Your questions and your experiences can help everybody. And so I'm going to start at the top of the Q&A and I'll kind of go down. If you have questions that you think of as we're doing this, please feel free to add them. We have about 35 minutes or so left in the webinar, so we should have time to address all of the questions. And so I'll start at the top. And the first question in the Q&A is somebody just saying they were able to sign in with the original link. And from all of the panelists, I'm sorry for the tech issues that we had in the beginning. We will debrief after this, and we'll see if we can work through some of that and get that smoothed out for our next webinar. So thank you for being patient and sticking with us, and we will try to do better in the future. So appreciate that. And then the second question is, will there be a recording or will this be posted somewhere? And then I think from an INSILC perspective, we're happy to do that. And to the other panelists, is everybody else comfortable with sharing the recording and making that available kind of across all of our channels?
Yes, I believe if we're doing it similar to how we've done it in the past, all of those who registered will receive the link. So if you have someone registered who had to miss or leave early, you will receive the link. But additionally, I think we can also be able to upload it in a YouTube link somewhere. Don't quote me on that, but I think that's probably going to be the easiest to disseminate that. So we will definitely keep that updated, but our plan is to have it posted somewhere.
It does take a few days to edit it, but then we will be able to get it posted. Yeah.
That's great. So yeah, if you were getting the emails for this webinar, then you should receive that, as Macy said, and again, follow our organizations for the up-to-date information, but we will try to push that out, I think, as many places as we can. Then our next question, what has been the typical annual spending increase in the most recent years?
Good question. I don't have those. I know it's been north of 8%. So it's been a significant spending increase. It's specific to Medicaid at the state level. If you would ask me, in March, I would have had those numbers for you, but I've since forgot them. So it's been large. It's been a lot more than the 2% that we're trying to maintain, or the secretary is trying to maintain as a goal.
Great, thanks, Tom. Appreciate that. Then the next question was another question about the recording, and so our recap, and so again, we will make that available afterwards. And then the next question, there has been no mention on family caregiver ATTC limits for both minors and adults. Can someone please discuss that?
I do not have that readily available, unfortunately. So attendant care for LRIs, that was part of the extraordinary care changes with the structured family caregiving changes. I unfortunately do not have that readily available on what the limits are. Rachel, if we're sending out information as a follow-up, I can try to pull that together and send that information in the follow-up as well.
Yeah, that would be great, Tom, if we could. Yeah, that way we can be responsive to that. I appreciate that. And then the next question is, hello, I'm in the process of sending my application in for the CIH waiver. With the changes happening, should I wait?
That's a great question. Do not wait. I would submit whether it's your CIH waiver or your family support, I would get your application in as soon as possible. Regardless of what the current waiver reset process will look like, there will be a wait list that will continue to exist. So at least at this time, that will be triaged then. And so I highly recommend, if you're looking to apply for a waiver, do it as soon as possible. And then also, if you're currently on a waiver, definitely keep up with your mail. And if you have any issues, whether it's questions on redetermination or anything of that sort too, I know the ARC of Indiana, Down Syndrome Indiana, Autism Society of Indiana, and even INSILC, we all have the capacity to be able to try to answer some questions if there's some issues on that back end. I know recently there's been some misunderstanding and also some miscommunication in terms of having to submit your income for some of these waivers. And so it's not a perfect system. And so the system wants to know what issues you're seeing, and they will try to be responsive. But yes, definitely send in your application 100%.
Great. Thanks, Macy. Appreciate that.
And I would like to just follow up that sometimes it's better to take it into the office and hand deliver it than to put it in the mail. A lot of those applications, once they're stamped, they know that they got them and you have proof that they got them, as opposed to just putting them in the mail or doing it online. So I would very much recommend that you take it into the office if at all possible. There's some better outcomes with that.
That's a good point too. Thank you, Rachel. Our next question, is it possible or probable that the HCBS waiver supports are presenting as more costly because more people are being institutionalized and being serviced at home?
So I'm just going to mention, I think it says because less people are being institutionalized and being serviced at home. So, I think there are several factors, and Tom, you can feel welcome to jump into with this question. There are several reasons why, and I don't necessarily think there's several factors. I think more individuals potentially applying and utilizing waivers. I think there are some waiver services that people are utilizing as well that maybe they haven't used in the past. So I think it's just so individually based with that. But Tom, you can jump into if you have any thoughts on that as well.
Yeah, that's a good question. I think that just the increase in number of individuals utilizing waivers wouldn't do it, because it's going to be an average based on usage. However, the point's well taken that if individuals were formerly institutionalized, they're going to have a higher needs in the community, and certainly that will bump up the cost for utilization. I think a really important key and aspect to this question, though, also is the calculation of what those costs are and how the costs are being determined. I think that's really important based on waiver specifics, especially as we get into waiver reset and kind of what that looks like. I do think there's also a factor over the last several years. I think that there, and rightfully so in some situations, was a mentality to maximize the budget as opposed to utilize services that were necessary and needed for the individual, because they were concerned about losing the budget or losing the amount of money. And I think that may have inflated the costs of what individuals need on the waiver. So I think that Kelly Mitchell with DDARS just presented at the DDARS Advisory Council last month or earlier this month. I don't know what date it is. And indicated a new kind of philosophy that really has been overarching the DDARS work, but is kind of going forward, is the right services for the right person at the right time. And I think that kind of goes toward kind of the collective on really individuals and families being recipients of Medicaid services and waiver services, recognizing the financial constraints that are being put on the program, to being good stewards of those dollars as well, and really utilizing the services they need and not necessarily maximizing the budget when maybe those services that are being added to maximize the budget are a rainy day service and an emergency service because you might think they're needed in the future. I think that's when that service needs to be pursued. And so I think collectively, when you have so many individuals on waivers, that may be inflating the cost of per individual usage too. So I think, as Macy mentioned, there's a variety of factors involved. But certainly, yes, I think that probably is one of the factors that more individuals are being properly receiving services and living in the community with the wraparound HCBS services that are designed to do, as opposed to institutional care. But I do think there's a lot of factors that go into that.
And I would just follow up that home and community-based services, when I was doing a research on the history of Medicaid, was really for adults, and it wasn't created necessarily for children. And so when they added that in later on, it became higher numbers, and then those individuals are on the system longer. And so they utilize the system longer, and the costs are longer for the lifetime of the individual, which wasn't a consideration when the system was built. The system was built for adults. So when you have like kids, for example, with autism and ABA, the cost there is astronomical, but they're children, right? So when they use that as children, that cost wasn't necessarily considered into the cost of home and community-based services decades ago.
All right, thanks everybody. The next question is, what is the rationale for capping relative paid supports?
So I'm guessing this is actually like LRIs, like legal responsible individuals, people who are relatives of the individual. This might go also with the next question, which is, what is the rationale to exclude guardians as paid staffing? I think that for one, I think the limitation on caps generally overarching on paid supports is guardrails potentially. I think over the last several years, especially as it relates to attendant care and legal responsible individuals, the costs were exceedingly high, and they really grew very, very quickly because they were being approved very, very readily. So I think putting guardrails on the cost is probably, from a state standpoint, cost containment is one of the reasons. Excluding guardians on paid staffing, I think that relates to probably the self-direction piece, where in the new self-directed service, guardians cannot be that paid staff. And I think that goes toward a potential conflict of interest protection. Self-direction is really the individual receiving services, making decisions about services they need and want. And in a situation where that individual has a paid guardian, it's going to be legally the paid guardian who's making that decision, who would then be deciding to hire themselves. So I think that it's a guardrail on a potential conflict of interest, is why it's being limited in that situation where it's self-direction.
Great, thanks, Tom, for answering both those questions. The next question is, will providers be limited?
I don't know what that.
Yeah, if you don't mind expanding on that question, we can maybe answer that more specifically.
Yeah, that's great. So if you could put that in the Q&A, then we will get to that as I get to that part of the Q&A. Thank you. Then our next question says, I'm currently on the H&W waiver and just went through my annual review. What is the possibility that I will be kicked off?
I think that is very, every situation is very different. So without knowing the situation, without knowing kind of other details, it's hard to answer that question. I will say right now, I would continue to, like I said, ensure that you're getting your paperwork in, you're paying attention to anything administratively that you need to do to continue that. And then also, the final decision is not always the final decision. Don't be afraid to appeal or do other processes. And if you have any questions too, I know the ARC, myself, and all of the organizations on here can talk through that situation by situation basis. But yeah, it's very independent on certain situations and it's very self different. So yeah.
I would just add too, just as a better, like a general good practice, best practice is to maintain all of your documentation. So, to Macy's point, be very, very timely on submitting those documentation whenever's being requested, but also keep copies because, we know things get lost. USPS is not the strongest right now. So if you're mailing it in, that's why Rachel mentioned dropping an office in person. But even when you do that, I think maintaining your copies so that you document kind of when you responded and what you responded is always the best practice.
Thanks, Macy. Thanks, Tom. That was helpful. The next question, is it more costly for the state to support an individual within an institution versus home and community?
I'm going to take this, guys. So,
Yep.
so importantly, I want to point this out. It is a requirement of the HCBS waiver to be cost neutral. So if we get to the point where waivers are costing more per individual to serve in the community than it is to serve an individual in an institution, the waiver will not be approved and can be removed from CMS, from the federal government. So that's a very, very important question and something to recognize. And again, going back to the good stewardships and taking what you need kind of situation, DDARS publishes this data on the costs to serve an individual per waiver, and then the cost to serve on how they're calculating per institution. It is more cost effective right now to serve someone in the community under the home and community-based services, but those numbers are surprisingly close. And if we get to the point where it's more expensive to serve them on the HCBS waiver, that waiver is not lawful anymore because that is a requirement of the waiver is for it to be cost neutral. So very, very important question and to point out. Also, this is not related to this question, but it's one thing I wanted to mention earlier on the provider tax because it's such a big thing and this kind of goes toward the funding aspects. Something to pay attention to. There's redistricting happening. There's discussions on redistricting happening. It has been implicitly and sometimes explicitly stated from different federal government officials that some of the waivers that we have in that are currently awaited from the federal government's approval on provider tax and state directed payment changes might be linked to whether our state legislator goes forth with redistricting. So just an FYI, these are all related sometimes. So there has been an implicit, in some situations, explicit retaliatory threats made about if the state does not move forward with redistricting, that may be tied to decisions on provider taxes and state directed payment approvals and allowances that the state currently has sitting at the federal government. I wanted to mention that earlier on the provider tax section, so I'm mentioning now.
Great. Thank you, Tom. The next question is, with the autism rate at 1 in 31 children now, and roughly a third of those being profound, how will this impact state resources?
Guess I'll handle this one.
Seems like a Rachel question to me.
Yeah, that's a Rachel. Yeah.
It's a big one. It's a big one, right? I was on the ABA task force, the working group that worked on the summer. It is imperative that we utilize all the options to help these families get the resources and the help that they need. That would be having a successful ABA experience and the transition into schooling or having appropriate schooling. And some of those recommendations were for incentives for the two systems to work well together in the future. So that was a future consideration of that, is that how can we get the two systems to work so it's more cost effective for these individuals to be and have utilized the services that are given to them or provided by the state currently in a cost-effective manner. So you're not in a clinical setting for your entire childhood. And that's where we are at currently. So we are trying to actively, although we don't necessarily think that medically necessity decisions should be made by the state, we do understand that there has to be cost-effective procedures for that to maintain the system so people can get the help that they need. And we are actively working to help families learn how to, again, have those trainings to do the services their own at home, because the research shows that not only if you go to school or to therapy and those children learn those skills there, it has to carry over at home. and through every day, all day long, to maximize the services and the benefits of those therapies that they receive. So although we do realize that the numbers are growing, we're trying to help those families and help the system work better in both educational and medical situations to curb that cost, and help there be ethical providers that can provide those services and help the families. It was hard decisions that had to be made or recommendations that had to be discussed that nobody wanted to discuss, but had to be done to curb those costs. And we did effectively curb that cost greatly if the recommendations are implemented in the future.
Thanks, Rachel. Appreciate that thorough answer. Our next question, has there been any discussion on the current laws in place and more individuals being born with disabilities and how they plan to support families with cutting funding to these programs? And I understand if you don't want to talk about this.
I think something that Tom had mentioned early on in the presentation is the 2% increase. I think that having guardrails on that increase is a way to not only address potential future, but also address the current fiscal, I think Tom said 8% growth that they're seeing and similar components of that. I'm happy to pass it off to if Tom or Rachel or Mike has any other thoughts on that as well.
No, I think that's exactly right. I think there's a variety of it's not one thing. It's cost containment and being efficient with the dollars that we have, and then also related to kind of the state match and maintaining and pulling down as much federal dollars as we can for the program. There's a lot of variables that go involved in place, and I don't necessarily think it's a state law change or a current law change. It's just a matter of a lot of strategic decisions to address that need.
Thanks, Maisie. Thanks, Tom. Our next question is, providers, I am one, determine what they pay DSPs for their services. My company pays DSPs $20 to $22 hourly for all direct support services. Our retention is above 98%. Staff support and pay is why retention is high. Our employees of 9 grew to 102 in 21 months. I wish not to be limited with what we can pay.
I think this question went to the, so I think she was expanding, they were expanding on the will providers be limited question.
Yep.
Yeah, I think that's important, extremely important. I think those three areas that I pointed to, right, that there's going to be considerations on eligibility, services, and rates. I think you are absolutely perfectly detailing why the rates aspect is so important, right? So it's retention of services, it's retention of quality, available DSPs to provide the services for services that are needed. I that's why we're battling all three of these, right? So I think we recognize, and you've articulated it well, why it's so important in a real world situation, why the rate cuts would be detrimental, along with and coupled with anything related to eligibility and services. So, we recognize that's one of the big three things that might have to change. And I'm not sure, I'm not saying there will be limited providers. And if so, how? I don't think they'll necessarily be, rate capped on what they're paying. But I think you've articulated that concern well. I don't know if anybody wants to expand on that.
No, I think that's a extremely valid concern, obviously with provider gaps. And I think also with a shortage in DSPs and other areas, it's important that is on top of mind. So yeah, thank you for raising that point.
Great. Thanks, Tom. Thanks, Macy. That is the last question we have in the Q&A. If you have another question, go ahead and enter that now. We can wait another minute or so, but want to make sure that we get a chance to answer all the questions. Then I'll go ahead and cover the resources and takeaway materials. So from the ARC of Indiana, they have some advocacy resources. They've prepared comprehensive materials, including contact information for elected officials, templates for introduction letters, and guides for effective advocacy communication. And the Autism Society of Indiana has some upcoming opportunities to stay engaged with our regular webinars, training sessions, and advocacy events. They'll keep you informed about legislative sessions and key advocacy moments. And then from Down Syndrome Indiana, you're not alone in this advocacy journey. We're here to provide ongoing support, answer questions, and help you connect with other advocates in your area. And then from INSILC, from the statewide Indiana Statewide Independent Living Council, we have a survey that we'd like you to take that will pop up when you log off of Zoom today. That is going to give you a couple opportunities to talk about the event today, what worked and what didn't, and also give you a chance to talk about the needs in your community. And then we'll take that and we'll use that on our current strategic plan, and we'll use that as well when we formulate our new one. And we will share those results as well with the partner agencies that joined us today. So be glad to share that and to keep collaborating. And then I want to let you guys know we're going to be back here at the same time for a public policy agenda webinar, and that's next week. So that's the same time on Tuesday at 1 p.m. Eastern. And we'll make sure that you get updated links and all before that webinar begins. And seeing, we do have one more question. Actually, before we go, we did have one more question come in, and that says, with numerous published data demonstrating a link from vaccination to autism, is it possible for thousands of families reporting this event in their child's disability of autism? Is it possible that the state of Indiana will pursue manufacturers compensating these families and recovering and removing them from the waivers?
Rachel?
I'm so sorry. I didn't want to get on. I was muted and the dog is barking at the people. So yeah, that would be a decision for the Attorney General of Indiana.
Okay, thanks for that, Rachel. And I don't see any other questions in the Q&A, so I think we've covered them all.
Sounds great. Well, with that, I think we can conclude the meeting. I know that we will be sending through how you registered supplemental materials from the meeting, but also feel welcome to reach out to our organizations if you have any follow-up questions, or if you'd like to get further involved in advocacy. Within our last couple sessions within the series, we did have some webinars that really focused on how to tell your story and how to meet with legislators. So I know the Mike highlighted that piece too. So I invite you to watch some of our past ones as well as session gets started. But thank you guys all for sharing. Thank you to the panelists for sharing and answering the questions, and we appreciate everyone's time.
All right, thank you, everybody.